Hello and welcome back to Quick and Dirty Med School. Today we'll be covering the thorax. So the muscles of the thoracic wall, they run perpendicular to each other. So here's the external, the most superficial layer, and notice how the fibers run downwards and forward. And deep to that is the internal intercostals, and it runs downwards and back. And then the innermost layer is the innermost intercostal muscle. And when you puncture these layers, the first thing you will encounter is the nerve. So there will be nerve injuries because that is the most superficial region, and it is enclosed in this groove. It's the subcostal groove. I like to remember this process as vein. So the innermost would be the vein, and then the artery, and then the nerve. So once you go more towards the ventral side of the body, so towards the front of the body, the anterior intercostal membrane replaces the external intercostal muscles right here towards the sternum, and the posterior intercostal membrane will replace the internal intercostal muscle behind the sternum. So the innermost intercostal muscle is related to the endothoracic fascia and the parietal pleura, and externally it also has the intercostal nerves and vessels. So the contractions of the intercostal muscles either pull the ribs up or down, but they pull the ribs nearer to one another. The first ribs are fixed by the scalene muscles, and those insert into the cervical region. And the 12th rib is fixed by the quadratus lumborum right here, that inserts into the iliac crest, and they're all innervated by corresponding intercostal nerves. So remember when we were talking about the dermatomes, herpes zoster is the viral infection. We know it as shingles, and it leads to the inflammation and degradation of the sensory neuron of the cranial or the spinal nerves. And look here, it forms these vesicles and inflammation, and is characterized by this erythema. It's very, very painful. And when it infiltrates into one of the spinal or the cranial nerves, it will affect the entire tract. That's why it follows a dermatomal pattern. See this banding? So it usually follows after a few days after the very first skin eruption, and this happens to anybody who's caught chickenpox. So please vaccinate your children. We don't want them having shingles when they get older. The Transversus thoracis, it arises from the lower third of the posterior surface of the sternum, so down here, and the xiphoid process, and it inserts into the sternal ends of the costal cartilage. There you go. And it's innervated by the internal intercostal nerve, and it is used to depress the rib and support the intercostal spaces and maintain the integrity of the thoracic cage. So it's important to note that we're viewing this from within the thoracic cavity. So this is deep to the sternum. So the subcostal nerves are best developed in the lower thorax, and they originate from one inner rib, and it inserts into the next. So if this is the origin, then it goes up, here's the origin, goes up. They're all innervated by their respective intercostal nerves, and their function is to depress the rib and support the intercostal spaces and the thoracic cage. All right. So there's 12 pairs of the Levatores costarum, and they're triangular. Here we go. Their origin are the transverse processes of the vertebra, and it inserts into a rib below the vertebra origin. So it will, if this is like let's just say T4, it'll insert into the rib below T4. So they raise the ribs, and they're innervated by the posterior rami of the thoracic spinal nerves. The serratus, let's tackle the posterior serratus first. So this is the superior origin from the cervical and thoracic spines, and it will insert into the upper ribs to elevate it. And the inferior origins are in the lumbar and lower thoracic spines, and they also insert into the lower ribs, and they work to depress the ribs, and both of them are innervated by the intercostal nerves. Anteriorly, there is the anterior serratus. It abducts and rotates the scapula up and elevate the ribs. They're known as the boxer's muscles because if you've ever seen like boxers or MMA fighters, they swing their arms like in a hook, right? So this muscle helps with that motion, and it's only really very, very defined in somebody who is incredibly lean, like 10% BMI, in order to see this. So here's the diaphragm. There are several origins. So in the sternum, at the sternal area, it will arise from the posterior surface of the xiphoid process. And then the costal area arises from the deep surface of the lower 6 ribs. Here we go. And their costal cartilage. And then the vertebral part arises from the crura and the arcuate ligaments. Here we go. And the right crus arises from the bodies of L1 through 3. Here is the right. And the left crus will arise from the bodies of L1, 2, and the intervertebral disc. So there is a central tendon that will attach. It will attach the diaphragm to the pericardium of the heart, and here's the medial, the lateral, and the median. It's not very defined here in this particular drawing, but the median arcuate ligaments attach it to the aorta. Here. It's divided into the right and left cupula, which will be better shown in the next picture. And it is innervated by the right and left phrenic nerves and by cranial nerves 3, 4, and 5. The sensory innervation comes from the central phrenic nerve and the sensory innervation of the central area of the diaphragm is innervated by this phrenic nerve, while the periphery over here is innervated by the intercostal nerves. So in patients with tuberculosis, this is actually a treatment for those lungs. So we section the phrenic nerve to paralyze part of the diaphragm in order to let the lung rest. Here we go. Here are the cupula. So the right, as you can see, is a little bit larger because if you imagine, there's going to be the liver underneath. And here's the left cupula. And here's the central tendon. And it works in inspiration. So, of course, when it contracts, it will assist in inhalation, and also when it contracts, it will assist in straining. So it raises the intra-abdominal pressure, and in weightlifting, it helps the anterior abdominal muscles to also raise the intra-abdominal pressure to support the vertebral column and prevent flexion. So whenever you're doing like a bent over row, the diaphragm helps stabilize the spine. Another function is the thoraco-abdominal pump. So it will decrease the intrathoracic pressure while increasing the intra-abdominal pressure in order for the blood to flow. So here are the openings. The central tendon lies right here, and that will lie at the level of the xiphisternal joint. And as you can see, here is the right cruce, and it will loop around like a sling. And here's the left cruce that will loop around the aortic opening. And there are several other openings we need to consider. The esophageal hiatus, and here's the opening for the vena cava. So this has the aorta opening. It has the aortic, the thoracic duct, and the azygos and hemiazygos veins. The esophageal hiatus conveys the esophagus, the vagus nerves, the left gastric vessels, and the lymphatic. And then the caval opening will transmit the inferior vena cava and the terminal branches of the right phrenic nerve. The sympathetic splanchnic nerve will pierce the crura, and the trunks will pass behind the medial arcuate. So back here's the medial arcuate. And then the superior epigastric vessels will pass between the sternal and the costal origin, so right around here. So there's several hernias we need to consider. They can be caused by the weak musculature around the esophageal diaphragm, whether being like a stroke or a traumatic motor accident. And there are 4 types. The first type is the sliding, where it just like the stomach will slide up through the esophageal hiatus. Type 2 is when it like compresses the esophagus and will protrude backwards. It could also protrude around and encapsulate the esophagus as well. This is really defined by GERD, so acid reflux. It's quite painful. This is the third type, where it will protrude back both like here and here. It's considered a paraesophageal. And the fourth type is the most dangerous, of course, because you can see the intestines will also herniate through. So these are all fixable with surgery. So moving on to a spinal tap. In adults, we will insert the needle and retrieve the cerebrospinal fluid at L4 and 5. So in order to do that, we find the iliac crest, and then from there we palpate it and go horizontally, and then insert the needle when the patient is lying lying in a fetal position. We don't want to have them sitting up. There's rare occasions where we do perform a spinal tap, usually in a morbidly obese patient, if lying down is not feasible for them. But we will palpate the iliac crest and kind of draw a imaginary line across, and then insert the needle. And we will pierce through the dura, like all through the ligaments, as you can see, into the dura, but we will not go into the subarachnoid space, because that can either introduce too much pathogen, or it will cause paralysis or damage to the nerves. And here's the mammary glands. All of The ducts and the lobules have a radial organization. It supplied the subclavian, internal thoracic, lateral thoracic, medial and lateral mammary, and the posterior intercostal vessels. And by that I mean both arteries and nerves. And the lymph drain into several nodes, but the important ones to note are the axillary, the abdominal, and the jugular nodes. The problem with breast cancer is that the epithelial cells of the lactoferous ducts around here, they will infiltrate and metastasize through the lymphatic channels because, as you can see here, the lactoferous sinus and ducts are like very, very close. And since there are no valves in the lymphatic vessels, they can spread essentially everywhere. So looking at an x-ray, the carcinomas are large and they're jagged, and they appear as white in the x-ray, and over top the skin is thickened into a term called peau d'orange. That means orange peel skin. And to treat this, we usually have like radiation therapy, chemotherapy. You can have a mastectomy where you will remove the breast tissue, quadrantectomy, which we will remove the tissue of the like quadrant, and a lumpectomy, which is of course just removing a lump. And there is the final one is a radical mastectomy where you will remove everything. So not just the breast tissue, but the underlying fascia and like whatever muscle you can like take as well. There's a couple variants. They're benign though. They're just aesthetically variant. So supernumerary breasts. You can have polymastia, which you just mean you have extra breasts. They usually occur in the axillary tail of the breast. Let me go back. Axillary tail like goes back that way, so usually there's like a extra little lump right here. And polythelia, which just means you have an extra nipple. It wouldn't be working, of course not, but it would just be there from developmental demigration. And like I said before, these are benign. They are easily correctable with plastic surgery. The surface anatomy for you to know is here's the posterior axillary line, the anterior or the mid axillary line, and the anterior axillary line. So easy to find. Just go straight down in the middle of the armpit, and that would be your mid-axillary line. And then from there, you can find the anterior and posterior lines easily. All right, that's it for now. Thank you for your attention, and good luck studying.